Good morning, everybody. Okay, so I'm Chris Eden, as she said, the new vascular surgeon here. So thank you for the invitation to talk today. We're going to talk about blunt thoracic aortic injury, which is a pretty heavy topic, so apologies in advance. I tried to keep it pretty light. It's early in the morning and try to keep everybody awake and get started. So thoracic vascular trauma, so we're talking about the aorta, the great vessels of the aortic arch, pulmonary veins and vena cava are pretty much all there is to it. And the majority of vascular trauma in the thorax is actually due to penetrating trauma, gunshot wounds, stab wounds, and very importantly, iatrogenic injury from people like us. But blunt trauma does have a unique role in thoracic vascular injuries as well, and so we're going to focus only on blunt trauma today. Just as a little side note, in terms of penetrating trauma and vascular injury, it's kind of the same everywhere in the body. We're plumbers, right? If you have an injury to a blood vessel, just fix it. Find where the blood vessel is good, find where the blood vessel is good, and put them together one way or another. And that's really all there is to it. But blunt injury is a little different because, as we'll see, it's not like, there's often not a defect in the artery. It's sometimes, the artery itself is just damaged, but still connected and things like that. So what do you do in those situations? According to the National Trauma Data Bank, the overall incidence of blunt thoracic aortic injury, which I'm going to refer to in this talk a lot as BTAI, is 0.3%. So not that high, but in 2010, BTAI caused 12,553 mortalities. So, not an insignificant number. And by comparison, we talk about other thoracic aortic conditions like aneurysm, dissection, the things that we see that are not trauma-related. So there were 12,553 BTAI trauma mortalities from this, compared to only 10,397 deaths from non-trauma-related thoracic aortic problems like aneurysm and dissection. So it actually is, by the numbers, more common than our sort of non-traumatic issues. After blunt trauma, aortic injury is the second most common cause of death. What's the first? Head trauma, which we're not going to talk about today. Let's see. All right, so what kind of blunt trauma are we talking about? Well, as you can imagine, the kind that causes significant force. And we can thank the modern combustion engine for most of those things. Car crashes, motorcycle accidents, people being hit by cars, and then one we can't blame them on the combustion engine, falls. But these are not falls from standing, these are big falls, usually from a height. So, as I said, you need significant force to disrupt your aorta. And so a lot of the things that are listed there are really just things that, cause significant force. It tends to happen most often, somewhat surprisingly in young people. I don't know really why that is. Maybe like young people are more likely to drive reckless or drive fast, or I don't know, but we don't see this as much in older people, so mean age 39. And more than 40% of cases involve substance abuse. So again, things that are going to get you into a high-speed car accident, things like that. Head-on collisions, ejection from the vehicle, if you see a steering wheel deformity for your front seat passengers. And actually, airbag deployment has been reported as causing BTAI at speeds as low as 10 miles an hour. So even just those airbags going off, so if you see, these things, obviously, as you're going through and examining the trauma patient and kind of deciding what radiology to order and things like that, this should definitely be on your mind when you know that there have been significant forces. And then, as I said, with falls, yes, falls not very exciting, but they tend to be falls from a height, so 3 meters or greater tends to be kind of a little there. So this is a graph or a chart that shows the associated injuries that often come with BTAI, and honestly, the presence of these associated injuries, which are often quite significant, are what make the treatment of BTAI difficult and what make treatment of the trauma patient in general difficult. At the top here, closed head injuries, 51%. So again, you have really significant forces. People have brain injuries. Rib fractures, we're talking about the thorax, that shouldn't surprise you. Pulmonary contusion, same thing. Liver injury, again, just lots of force. And pelvic injuries, same story, long bone fractures. And I wanted to point out as well, in addition to these other injuries, that at the bottom of the list there, they listed none, which has a whopping 0% next to it. This is never an isolated injury. That's sad. So what are we actually talking about here when we say BTAI? The most common site of injury to the aorta is the proximal descending thoracic aorta at the isthmus. And the isthmus is kind of pointed out there on that little cartoon for you. It's right, just kind of right in the same area as the ligamentum arteriosum. And when I was in school, they taught us that the ligamentum arteriosum was sort of the reason why people get it there, because it's tethered. But that actually doesn't make any sense, because the pulmonary trunk would tear before the aorta would tear. So that doesn't really make sense to me, but what does make sense is that the descending thoracic aorta is right up against the spine there and is pretty immobile. Compared to the arch and the ascending aorta, which are attached to the heart, which is, by comparison, more mobile, and the isthmus is the area kind of between these two. So it is kind of the junction between a more mobile segment and an immobile segment, which is why that's where the injuries tend to occur. But, you know, sometimes you hear about the ligamentum arteriosum. I don't know if there's any truth to that or not. But the truth is that BTAI can occur anywhere in the aorta, so it can happen anywhere. And then, you know, just as a image, this is obviously a postmortem, somebody's aorta. You can see the heart to the left there, and the tear kind of right at the isthmus. Those are the great vessels of the arch. You know, the aorta doesn't exactly look like the cartoons typically, but so this is like a real life picture of what like a grade 4 rupture would have looked like in someone that died from that. And the best things in life come with a classification system. So here we are with a nice classification system. It's actually fairly useful in terms of research, tracking, recording, but also for how to manage these things and what to expect. Like how do patients do when they suffer this. So a grade 1 injury there on the left is just an intimal tear, and this is best seen on a CTA or with an IVUS, intravascular ultrasound, so not like a bedside ultrasound or a fast exam or a TEE or any of that stuff. This is going to be intravascular. But that's just an intimal tear, and the way you can tell an intimal tear from an intramural hematoma is that there's no external contour abnormality on the aorta. So if you look at the aorta and you look at it, typically, you know, if you're going to look at the aorta on a CTA, you're going to look at it in all its projections. You're going to look at axials, you're going to look at sagittals, you're going to look at coronals, because it looks different in all those cuts. And you're really looking for that contour abnormality. If you don't see a contour abnormality, but there is an intimal defect or like kind of like a flap or something there, then this is a grade 1. Grade 2 is an intramural hematoma. This is when, if you see an aortic contour abnormality, you're automatically a grade 2 or higher. And these injuries involve the media, so the middle muscular layer of the artery. And dissections fall in this category as well. So if you actually have like dissection, then it goes as a grade 2 as well. Grade 3 pseudoaneurysm is where you actually have disruption of the media, and it's sort of you can think of it as sort of a contained rupture. It's still within the adventitial layer of the vessel, but there is it's not just an aortic contour defect. You actually see flow outside of where the lumen of the aorta should be. So that would be, it's not a blush of contrast, but you're just going to see contrast outside of where the aortic walls should be. And then a grade 4 is a free rupture. So in terms of imaging evaluation, most of these patients are going to get a chest x-ray, as one of the first things when they come as part of their sort of initial evaluation. So we should talk about the chest x-ray and the signs. So obviously in your chest x-ray, one of the things you're looking for is hemothorax, pneumothorax, and rib fractures, things like that can kind of tip you off, and obviously may need to be treated, in their own right. And then a normal upright chest x-ray has a negative predictive value of 95 to 98%. So if you have a normal upright chest x-ray, the odds of having BTAI are really quite low. But remember that 98% does not equal 100% in this or any other presentation you will hear today. And the other thing to point out here is that, I love these radiology statistics, but the reality is not a lot of trauma patients are getting upright chest x-rays because they have spine precautions and all these other things, and you're going to get a supine x-ray. And of course, they don't tell you the statistics for a supine x-ray, so here we are. But things you can find on a chest x-ray that will suggest BTAI, in addition to mechanism of injury, things that will tip you off are unusual high-force fractures, sternal fractures, scapular fractures, clavicle fractures, and first rib fractures. So not the other ribs, but the first rib in particular, because you have to suffer a lot of force to have a first rib fracture. Obliteration of the aortic knob, which I think is sometimes a little hard to see on a chest x-ray if you're not a radiologist with a ton of time to examine these films. Apical pleural cap, deviation of NG tube, or lateral displacement of the trachea. Obviously, those things are going to be deviated to the right, not the left. And loss of paravertebral pleural stripe and widening of the mediastinum. So, the radiologists love this stuff, and they have, all their little criteria, like what's a widened mediastinum? Well, it's like 8 centimeters or like greater than 25% of this measurement, things like that. But the reality is that if you look at the chest x-ray on the left, like how many of you would have thought, oh, that NG tube is deviated? Versus how many of you would have thought, maybe that film's a little rotated or something, I got to be honest, in the midst of a trauma, I'm not sure I would pick that up as a deviated NG tube. But this is literally in a radiology presentation about, like, what is a deviated NG tube. Okay, so, when you think deviated NG tube, you're like, it's got to be way over, like, in the middle of the lung on that side. Well, no, it's like, it looks like that. So the reality is that, you can be suspicious from a chest x-ray, but you're often going to just be suspicious and not really quite sure unless it's like a major aortic rupture. So CTA is king. I was trying to find a king graphic, and they were all terrible, so I went with Mufasa instead. So I don't own the copyrights to Mufasa. But hopefully this slide is memorable. CTA is king, CTA is king. And, trauma patients are getting a lot of CT scans. The PAN scan is, definitely an acceptable way to image these patients that have had high-velocity motorcycle accidents, car accidents, things like that. And the CTA is definitely the best way to look at these injuries, and also helps us with operative planning. So you kill 2 birds with 1 stone when you get that. So it is the screening modality of choice. Indications are really kind of all the things we've been talking up to now. Suspicious mechanism of injury is probably the first thing. But if you have, some of those signs we talked about on an x-ray, or clinical signs, you should just get a CTA. And so you can see some cuts here of this patient, you know, and this is one of the things, I mean, that's a 3D recon on the other side, which I wouldn't worry about, but, you know, you can see how it looks in the axial versus the sagittal there. And they do look different, and they do help you kind of determine the extent of the injury. So, you know, you can tell that, you know, this is probably a grade 3. The person does seem to have, you know, periaortic hematoma kind of going all the way down. But you can definitely see that the contour of the aorta there is probably not what it should be. So. TEE, they talk a lot about TEE. It will diagnose a BCAI most of the time. It won't be able to assess the ascending aorta or the aortic branches very well, but it does get a good look at the descending thoracic aorta. But the reality of being able to do this in a trauma bay, in a trauma situation, is not very easy. Again, you're going to have C-spine precautions and all these things that, you know, make it unreasonable to think that you're going to be able to position a patient for a TEE. And it also requires specific training and expertise that is probably not readily available most of the time. And you're going to be able to get a CT faster than you're going to be able to get this. So although they like to talk about this, only 1% of thoracic aortic injuries of any kind are diagnosed with TEE, so CTA is king. IVUS, so I mentioned this earlier as a way to examine aortic injuries. This is an invasive ultrasound, so we do this in the operating room under certain circumstances, but it is real time. You get a 360-degree image of the aorta. It's a pretty miraculous little device, high-frequency miniature ultrasound probe. It is a teeny tiny catheter. A lot of the devices that we use in the vascular lab are quite large, as we will talk about, but this guy is like the size of a diagnostic catheter. He's really quite small. It does require an 8 French access, so pretty much no big deal there. And no contrast and no radiation. So we use this sometimes in vascular cases in patients with renal issues when we're trying to save contrast. So it's actually a really nice tool. Aortography. So this is invasive and it's expensive. This is when you would be actually like putting wires and catheters up through a femoral access and shooting dye to like shoot your aortogram. This is the quote unquote gold standard, but like that definition is decades old, so nobody does this anymore for diagnostic purposes. But it is also therapeutic, and so you're gonna shoot an aortogram when you're in there preparing to fix it. So MRI, long exam times, not commonly used. And according to what I was reading, most useful in detecting the hemorrhagic component. But, you know, it can be used in patients with renal insufficiency who have contraindication to CTA. But again, I think the reality of getting an MRI in a situation with a patient that's going to have multiple traumatic injuries, and this is one of them, is probably not terribly reasonable. All right, so I would show you that CTA is king slide again, but it's probably old by now, so you get the point. So what's the immediate management of these patients? Historically, this is a really deadly injury. I think the first successful repair was in like the 1950s or something, but patients typically died in the field, or if they got to the hospital, they died within hours of getting to the hospital of aortic rupture. But in the modern era, they've reviewed that old data, and less than half of those patients had an injury at the isthmus, compared to the modern era, where the vast majority of our injuries are at the isthmus. So either between the 1950s and the 2000s, there's been a mechanism change, motorcycles, cars, things like that, or it's just a review bias. You know, a patient with a grade 1 injury in the 1950s, you don't have CTAs, you may never know that person even had an aortic injury. So, whereas now, every little paper cut on the patient gets discovered somehow at some point during the workup. So, I think it's a little bit of a bias injury. That being said, aortic isthmus injuries do seem to be more stable than other aortic injury locations. The goal of immediate management is just prevention of rupture. So again, these patients are really complex, and it's a difficult situation because they suggest aggressive blood pressure management. And when I say aggressive blood pressure management, that means typically esmolol infusions, labetalol infusions, beta blockers are going to be your first line, followed by vasodilators. But the goal is really a systolic under 100 or a MAP under 80 with a heart rate less than 100. So you really try to get these patients pressured down. Well, sounds nice, right? Not as easy to do, and maybe not good for their concurrent traumatic brain injury. So here you are. And that's what makes these difficult cases. So in the modern era, the BTAI is not typically the biggest problem. The associated injuries are the most common cause of morbidity and mortality for these patients. So it's going to be your shattered liver, your closed brain injury, your whatever some of the other ones I said were. That's what's going to cause the morbidity and mortality in these patients. And therefore, delayed repair of the BTAI, I'll just stick to that, has been advocated since the 1990s and is actually a very successful method of repair. Remember that when we fix blunt thoracic aortic injury in the modern era, we are using stent grafts the vast majority of the time. And whether you are using a stent graft or not, these patients have to be therapeutically heparinized. And so when you have a shattered liver, you don't tolerate therapeutic heparinization very well. So if you can kind of delay the repair of this for, 24 hours, 48 hours, a week, whatever you can tolerate to let them kind of recover from their associated injuries, that's typically a good thing. And so, basically, when these patients come in, you're going to look at the patient as being in one of two categories, right? They're going to be stable or they're going to be unstable. If they're unstable and they have a traumatic aortic injury, overall mortality is, from all causes, is over 90%. So it's a pretty grim situation. But in the stable group, a stable patient with BTAI, all-cause mortality is more like 25%. So it's definitely a manageable situation. But if you're managing a patient medically with blood pressure management or, whatever, and they start to experience hypotension, anuria, you see an increase in pleural effusions on the chest x-ray, they develop limb ischemia, maybe you rescan them and see free liquid conscious. So these are bad things and basically indicate impending total rupture, if not already ruptured. And you should abandon medical management and proceed with operative intervention immediately. So you're going to know that something is going south with those patients. So if you look at early versus delayed repair, I'm going to try to boogie through this a little bit because I think we're almost out of time. But if you look at early as within 24 hours, so these are the people that are coming to your trauma bay and you are taking them to the OR and fixing this rapidly, versus delaying it greater than 24 hours. The delayed group has been shown in multiple studies, not just this one, to have significantly lower mortality rates. And it's felt that that's due to better resuscitation, better optimization, treatment of the associated injuries, and again, not giving someone that shouldn't have therapeutic anticoagulation like right out the gate. TBI does earn a special mention. I kind of already talked about that though, because they're often not as good candidates for delayed repair But again, these decisions just have to be individualized with every case because there's no easy answer in that situation. They're not going to tolerate hypotension. Maybe they're not going to tolerate anticoagulation. So, you know, can you fix it or are you going to not fix it? And it really becomes an individualized decision. So the classification put to use, grade 1 injuries, typically medical management. These patients often never get a repair. So medical management and serial imaging. Usually, if I'm seeing a patient that has a grade 1 VTAI, I will usually say, you know, medical management, blood pressure control, all this stuff, and then I usually scan them again before they leave the hospital. So by serial imaging, we mean like pretty short-term follow-up, and then I'll usually scan them like, you know, a month later or whatever to like make sure that it's healing. Grade 2 and 3 in a stable patient, you do elective TVAR. So again, this is our delayed repair. You're probably going to do it prior to discharge, but you're not going to do it right away. You want to let them, you know, get over the initial associated injuries. And then grade 4, you're going to be fixing emergently because that person is rapidly dying in front of you. And then, of course, the TVAR recommendation assumes anatomic appropriateness. It is, I think, important to note, actually, on this slide that the recommendation from the Society for Vascular Surgery is for TVAR in any and all cases where it's appropriate, and that recommendation has been standing in the national guidelines since 2012. And in 2012, there were no FDA-approved devices for this. So the SVS actually made that recommendation knowing that there were no FDA-approved devices for this purpose. So that should tell you right out the bat how strong of a recommendation that is. They're like, we know it's FIFU, do it anyway. And that's from a national society. Okay, so TVAR, what do we do? Bilateral femoral access can be open or percutaneous. Most people will go percutaneous when they can. Some people still prefer open exposure, dealer's choice. Typically, you get bilateral access. It can be done with a single access, but it's faster and easier with bilateral access. On one side, you're just going to have a 5 French diagnostic pigtail catheter, that thing with all the dots on it going up. That's a marked pigtail catheter. You're going to use that for measuring things during the case. And then the large access side is for the endograft introduction. This is typically I'm not supposed to say product names or brands, but in one of the very new endografts that is considered smaller profile than some of the other brands' endografts, they are advertising 19 to 22 French, so that is actually small access. And some of the other brands and products go up to a 26 French. So for size reference, those of you who are not that familiar with French sizing, a 20 French catheter is probably slightly bigger than my pinky. So that is a big percutaneous access. And this is what you're putting in. This is just an example of a thoracic endograft. It is here showing off its flexibility, but just so you know, it's got usually nitinol struts, and it's covered with either Dacron or PTFE, depending on what brand you're using. And they're friction fit, so there are no like fixation devices or prongs or anything. They're friction fit, so you oversize these in the aorta. If your aorta measures, 24 millimeters, you're going to oversize your graft by 10 to 20%, so that it, sits in there by friction, basically. LSA coverage, we're kind of running out of time, basically. Okay. So left subclavian artery coverage. So if you look on here, so your left subclavian artery is the third branch on the arch. And you can see kind of where that pseudoaneurysm is on this aortogram is right kind of in the area of where the isthmus is, right? That's where they always are. Not always. But they recommend 2 centimeters of aortic coverage to adequately seal an endograft because, again, they're friction fit, so you really want 2 centimeters before the injury to get that graft sealed, which sometimes is not feasible without covering your left subclavian artery. And you can do that, and we do it all the time. But it does have risks. So your risks are basically left arm ischemia and stroke. And the stroke is really because you're covering the left subclavian artery, which feeds the left vertebral artery, which is sometimes the dominant vertebral artery in the brain. So you do have a stroke rate associated with that. It is not recommended to revascularize the left subclavian artery in everyone. Typically in a trauma situation, and I say that specific to the trauma situation, in elective cases for aneurysm and things, you do always revascularize because you don't want to accept that stroke rate. But in a trauma patient, you just do it and then see how the patient does, and you can revascularize the with a carotid subclavian bypass after the fact if the patient is symptomatic. So that is the recommendation. They are starting to have branched TVARs, which involves like laser fenestrations, and a couple of companies are starting to come up with branched endografts off the shelf, things like that. We're not there yet. That's still a very emerging technology, and those are difficult cases that take a lot of time and are not as reasonable in a trauma situation. But carotid subclavian bypass is what you would do to fix this. And that's another major operation that you don't want to have to do if you don't have to do it. So typically you just cover the LSA and see how the patient tolerates it. Most people tolerate it fine. Outcomes, in a single center review of 140 cases of BTAI, survival rate in a grade 1 injury was 100% versus 76% survival in grade 3 and 11% survival in grade 4. The TVAR is not free. These patients have to follow with a vascular surgeon for the rest of their lives. And the only way to surveil a TVAR is with CTA. So TVARs and CTA, when you have a car accident when you're 29 years old and you have to have a CTA, every year for the rest of your life, the rate of renal failure long-term for these patients is very high because they get contrast over and over and over to surveil these grafts. We try to minimize that as much as we can, but you can imagine if you have a problem with your thoracic aortic endograft, it is not one you want to miss. So surveillance is really important. Overall mortality for TVAR is 7.2% versus the almost 24% for open repair, like in the olden days before we had TVAR. So TVAR is definitely the way to go. Paraplegia for TVAR is very unusual in the trauma population because you're typically using short endografts. 10 centimeters is the shortest endograft that exists, and that's typically the only piece you need. Paraplegia is a big deal in other thoracic aortic repairs, but it's more common when you start getting up to lengths of 20 centimeters. So these patients have a very low paraplegia rate. Versus if you're repairing these open, the paraplegia rate is, I saw 15%, I saw 19%. That's a real number, and that's a bad complication to have. And then your stroke rate, again, is significantly lower in the TVAR group. So just overall, TVAR is definitely the way to go for these people. Open surgery, I just kind of put this here just to say it, but the overall mortality is quite high. And when I'm looking at that figure A there, this is a clamp. This describes a clamp and sew technique to repair a descending thoracic aorta. That repair should be done with a TVAR. I don't think anyone would ever do that if they could avoid it, and there's really no anatomic reason in that configuration to not do a TVAR. So this is more of historical interest. If you are going to do an open TVAR, it typically requires distal perfusion of the aorta, again, to lower your paraplegia rates and all these sort of things. So these patients often require a bypass for that. So that's kind of demonstrating a simplified bypass circuit over there. So you're going to be calling cardiac surgery, not vascular surgery, because we don't run the pump. But you're also going to be calling cardiac surgery if you have an ascending aortic injury or an aortic arch injury, because those patients often need sternotomy, they need bypass, sometimes they need hypothermic arrest because there's nowhere to put a clamp proximal, like the only thing proximal is the heart, which you can't clamp, so you're going to be going on hypothermic circulatory arrest and you need a cardiac surgeon to do that for you. So these are highly lethal, bad situations to be in. So that's all I'm going to say about that. And then our other arterial injuries, just worth special mention, there are other arteries in the chest that are not the aorta. The innominate artery deserves special mention and makes a nice illustration here. It's the second most common injured artery in the thorax after the aorta for blunt trauma specifically. And that little 4-panel image over there is like, you know, when you read the textbooks, they're like, oh yeah, you don't have to clamp the aorta, you just use the side biter clamp, which is, this is a Satinsky clamp, side biter clamp. You put a side biter on the aorta, and then you just end-to-end repair the innominate artery, like that nice last picture you see there, and oversew the innominate stump. Well, that's a lot harder than it sounds, but that is the repair. But the good news is, as I said, with the Satinsky clamps, aka side biter clamps, you don't need cardiac bypass most of the time to fix this. That being said, I've done exactly one of these, and both vascular and cardiac surgery were there. So I don't even know if I have privileges to do a sternotomy, so you probably would want a cardiac surgeon there. And that's it. Any questions?
That was great. I want to open it up to the audience for any questions, but I just had a few questions. We have, you talked about the difficulty of managing these patients in multi-trauma, and that is the case. You know, in the field, you know, when EMS brings a patient in, you know, they see, you know, significant blunt chest wall injuries, and they have other injuries, head trauma, it becomes extremely challenging to manage. Do you allow hypotension, as you mentioned? So the field is really a difficult place to be, and that's where, again, you know, when we work on identifying opportunities for our trauma system to get stronger and so that patients can get the right care at the right time just as quickly as possible, that's key. But I wanted to ask Dr. Stemler about this. I am always amazed when it comes to the wide mediastinum, right, and the supine images. How do you guys deal with that? Because in a supine image, I mean, you see X-ray after X-ray after X-ray. What's your approach to that?
So, you know, I think the big issue with that is, right, usually these are, the supine and upright, that makes some difference, certainly. But usually these patients have a very hyperventilatory exam, right? So everything is crowded, right? So you push everything up, you're going to automatically widen the mediastinum. To me, the more relevant thing is to look at contours, right? Do you see contours that you're supposed to see, right? If everything is blurred out, right, you say, okay, look, that doesn't look normal, right? So it's more of a gestalt rather than having calipers and saying, look, this mediastinum for this technique is inappropriately wide. And obviously comparisons, right? So if this is not something new to the system and we have an old comparison, we say, look, aortic arch was totally normal before, now it's twice the size, something has happened, right? So to me, it's looking at it, right, putting it into context. If we have comparisons, those are always helpful. But yeah, I think, you know, most of us will err on the side of saying, look, this looks a little bit wide to us, you know, pay close attention to the aorta on a CTA that follows up. So that's probably my general take on that.
Yeah.
And the associated findings, right? Yeah, you know, everyone wants to publish and so forth. So there are documents out there that the first 3 ribs are increased risk, not just the first rib and so forth. There are measurements for apical caps, right? So a lot of people have pleural parenchymal thickening in the apices, right? So that's their baseline, right? So you have to see something asymmetric to the left side to be concerned about and so forth. So ancillary findings are helpful, but to me it's more of what does the aorta look like, right, given the technique and everything else. And then, you know, if there's any doubt, obviously, you know, these patients almost always go to CTA, right, and look at that. So, yeah.
Yeah, it's just, you know, because we're all taught to fear the wide mediastinum, and
yeah, I mean, if you were just to make measurements and say, look, if it's going to be more than a third of the mediastinum, more than a third of the transverse diameter of the thorax on a portable film, you'll be calling that all the time, right?
Right.
So you really can't use that as a guideline. To me, the much more helpful thing is, right, what do the contours look like, right? Is the arch there where it's supposed to be, and is it distinct? If it's not distinct, you're like, okay, that's not normal. Either there's hemorrhage up against the aortic arch, right? There's atelectatic lung up against the aortic arch. Something has happened in that area, right, that is obscuring that normal silhouette. So that is a much more helpful sign to me to say, okay, something's not right in that area. It doesn't mean the aorta is abnormal, but something next to the aorta, right, that is essentially obscuring the normal interface between lung and aortic arch. Something has happened here. So that's what I would look for.
Okay.
That's what I do look for.
And then I'm not very familiar with the intravascular ultrasound. Is that just an operative room approach? We wouldn't. That's where it would take place.
Yeah, it's an invasive catheter. So usually for us, in a trauma situation, it's not used very often, but it can be used in this situation to determine like extent of injury. I use it most commonly in conjunction with fluoroscopy because when you fluoro a patient with an IVUS catheter in, you can see the IVUS catheter. So you can shoot an aortogram and say it's an injury that you can't see on an aortogram, like intramural hematoma.
Yeah.
You may not see that on the aortogram because there's no active blush of contrast. There's no, that aortic contour deformation you're not going to see on fluoro because it's not involving the lumen, which is really all you see on fluoro. So what you can do is shoot your fluoro, and then we road map it, so you mark it on the screen, literally mark it on the screen with a dry erase marker, like this is where the subclavian is, this is the, you just outline it. And then you can send your IVUS catheter up, and you're looking at the IVUS screen, and you say, okay, there's the injury. And then you fluoro, and you say, okay, yes, it's 2 centimeters past the subclavian. And there are other ways to do that without relying on fluoro so much. You can literally just IVUS the whole thing. It's a little hard to get distance measurements like that because it depends on like how fast are you pulling the ultrasound in or out. But yeah, it is purely an invasive method that would be done only in procedural suite.
My last question has to do with the fact you alluded to that in general, this seems to be a younger population than our trauma average age. And so long-term follow-up for these patients is extremely challenging. This is really a question for both Dr. Stone and Dr. Eden. How do we do this well? Because I think that one of the best programs is what radiology has done with IVC, catheters, just a database where it's closely monitored. What are our methods available to us now to track this population? What is the interval and how long do we track these patients?
Yeah, I think unfortunately a lot of the burden of making sure these patients end up getting surveillance is on the patient themselves. And so a lot of that has to do with just educating them prior to discharge on like, hey, you have this device in your chest now. Sometimes the word device scares them. Mm-hmm. You have this device in your chest now. If something goes wrong with it, that can be fatal. Something can go wrong with it in a month, in 35 years, and it just has to be watched because, and we don't really have long-term data, like decades and decades, because stent grafts just haven't been around that long. But some of the long-term complications that can happen with stent grafts like this is like, stent fracture or strut fracture, things like that. And so it can be really dangerous. And so I think just like expressing to the patients like, you're okay, but we have to keep an eye on this, and it's up to them. I mean, I saw a lady in my clinic just last week she's like in her early 30s, and she was in a major car accident out in Idaho Falls, and she came here, she lives in Boise, but she was out there when she had her accident. They did a TVAR on her for a grade 2 injury prior to discharge, and she came back to Boise and went to her primary care doctor and was like, I need to be hooked in, with surveillance, and they sent her to me for surveillance. But she could have just as easily come home and been like, oh, that was nice, I'm good,
So can I tell them before they leave the hospital if they don't follow up, their heart could explode?
Probably not. No. Probably not fair to say that. But, and for surveillance, I mean, the recommendation is really annual surveillance. In reality, you do risk, a lot of contrast over someone's lifetime if you're going to scan them once a year from the age of 30 to 85, it's probably overkill. So I usually try to space it out more than that. So like in that young lady that I saw, she had a scan 6 months ago. I'm going to scan her in 2 years because I'm just trying to kind of space it. She's got a lot of years to go.
What about MRI for follow-up rather than CTA with contrast? I don't know if there's a difference in renal failure rates and also ionizing radiation exposure over time.
Yeah, from my perspective, we certainly have done a handful of cases for this indication. It's generally speaking, resolution is not as good, right? So you're going to see obvious defects and that sort of thing. You don't see the grafts out well. There's always some artifact associated with it. So the specific, concern is, I want to know graft integrity. MRI is not going to tell you that, right? Unless you have a wide gap, right, that is displaced by like 2 centimeters, something like that. So it's not good for that. It is probably reasonable, to look for like endoleaks and so forth. People have done that for people that have, abdominal aortic endograft and so forth. So I think it's an option. From my standpoint, there is more and more emerging data for contrast-induced nephropathy, and that's actually probably a lot lower than we used to think. So we will give people that have borderline renal function, give them the saline bolus, right, and as a hydration protocol. So I'm not personally that concerned about even long-term renal insufficiency with, annual, as long as it's not doing every 3 months kind of thing, iodine doses. But my concern is for this age group, right, you're doing long-term surveillance CTs in relatively young patients, and the radiation dose is not, it's come down. Similar doses nowadays for even gated studies and so forth is a lot less than it used to be 10, 15 years ago. But you're going to give these people a lot of radiation during their lifetime, assuming they survive these injuries, right? That's a concern to me, right? Especially for women, right? If you've got childbearing women, the breast glandular dose is pretty significant for a thoracic CT or a CTA in particular. So that's the kind of thing where you want to minimize how often you expose them to radiation in that age group. People over the age of, like I said, I hate to make this arbitrary distinction, but once you're past your 40s, the chance of you getting radiation-induced malignancy is almost zero, right? So it's that 30 to 50 age group that we have to be very cautious about. Once you're past that, right, I don't think radiation should be concerned. So, yeah, I think you want to minimize how often you do these things, but for many indications, CTA is the preferred modality.
Yeah, and I think in the trauma setting like this, like if you're doing, a grade 2, it's not the same as surveillance for, a TVAR that you did for aneurysm, where you really are looking for, you're looking for sac expansion, you're looking for endoleaks, you're looking for things like that. If you're doing a grade 2 TVAR for a blunt thoracic aortic injury, you're more looking for graft integrity, and you're not going to be looking, obviously, you look at everything, but your concern is not endoleaks, so it's just a little different, and in the abdominal aortic arena, we use duplex instead of CT a lot of the time now, and that's been shown to be, as effective at picking up, sac expansion and endoleaks and things like that, but you can't do that for thoracic, so unfortunately, CT's kind of worth that.
And I don't even know if this is even a thing, but it seems like the injury happens, you put this stent, and then the injury heals, and then are there any removable or dissolving grafts?
No, there are not. And I think that statement that you made about, the injury healing is why we no longer repair grade 1s, because we know that their risk of anything bad happening is so low, and it will heal on its own. So you don't want to put this big hunk of metal in somebody if it's going to heal on its own. So you're really kind of just weighing the risks and benefits of doing an intervention versus leaving it alone. And that's why we no longer fix grade 1s. I think, when this was initially coming around, they were fixing everything. But we know now that that's not necessary. But no, there are no removable grafts. There are no dissolvable grafts. These were all adapted from endografts. As I said, initially there was no FDA-approved device for this. They were FDA-approved for thoracic aneurysm and dissection. And so these devices, have all kind of been adapted from that, those initial grafts.
The one caveat I want to mention about CTA, you know, for our trauma CTAs, we do not gate, because obviously that increases the dose and the time of the exam. And certainly in some patients who are, you know, hyperdynamic and tachycardic and so forth, you'll have very pronounced pulsatility artifact in the aortic root and probably the first 3 to 5 centimeters of the ascending thoracic aorta. So you have to kind of read through that known artifact that you're going to see in these cases. And so if there's a concern, like aortic isthmus, usually there's not much motion there. You shouldn't have any complications or challenges there interpreting that. But if we're, like I said, look, the aortic isthmus is abnormal, but we still see a lot of pulsatility in the aortic arch, and we don't know where exactly the injury starts and ends, right? So one of our goals is to localize the injury, right? Describe the injury as far as, you know, contour abnormalities, intimal defects, intramural rents, and so forth, but also to describe, okay, where does it start, where does it end, right? So that it helps guide the surgeons in preparing it. And if you can't tell where it starts, you know, you're going to have to repeat the exam to do a gated study. Now, we do have sort of some techniques to kind of reduce the motion, right, where we do a half scan reconstruction. We'll do that if we think it's going to help. But sometimes the pulsatility artifact is so pronounced, even that doesn't help with that, right? So there are cases where we're going to have to actually do a second scan to define the anatomy. That doesn't happen very often. I mean, I'd say, you know, these cases don't come up very often in our system. I'd have to see what kind of data we have here, right? But we probably see maybe a handful of these cases a year, right? So one every couple of months kind of thing. So they're not common injuries, and like I said, sometimes it is impossible to decide, you know, where is the injury, right, to localize it.
Is that where intravascular ultrasound really, you know, comes into play?
You could. I mean, I think if you had some question of, you know, is there an injury, is there not an injury, and if, you know, what's the extent of it, intravascular ultrasound can be helpful for that, because you will see like the intimal tear, or you will see the hematoma in the wall of the vessel, and you can kind of say like it goes from here to here. But again, it's invasive. So what are your, you know, so what are your options? Well, if the patient's stabilized and recovering from their other injuries, you're either going to rescan them, you can do an IVUS, or you could do TEE, unless, of course, you're talking about the ascending aorta, then, you know, you're not going to see it on TEE. But, you know, there are options for evaluating it. But, I mean, I would probably rescan someone before I would do IVUS, just because of the invasive nature of IVUS. But it is a big thing to have to do either way, you know, either repeating a scan or doing an IVUS. You know, neither is convenient, but...
Well, thank you so much. That was a really great, Alexa, great overview